Does everybody generally, I know, again, three quarters of you have one of these already. But the basics on how the system works, the technology behind it. So this is all based on acoustic geometric imaging. It's using sound waves to measure cross-sectional area as a function of distance. So I want to address some of the misnomers and some of the myths and some of the questions I see people ask all the time out there. But the first thing is it's not measuring airflow or air volume or air anything. It has nothing to do with that. The breathing that we're doing with this is simply a way to manipulate the airway into flexing and changing and doing what we want to do with it, but it's not measuring anything as far as flow. It's strictly size. How big is the opening as it travels further and further down the nasal and oral airways. During the testing, you hear all the clicking. The clicking is sound waves. Every click is one sound pulse shooting into the airway. It reflects out. There's microphones in the tube. Those microphones pick up the reflection, and it maps out, like I said, cross-sectional area as a function of distance. So essentially what you're left with on the screen during the testing is you have a graph up here, and there'll be a line on it, and I'll run through the test actually, and then we'll explain what that line means.
Now,
So,
what about awake or asleep?
okay, well, I'll do that. I'll address that with pharyngometry, because that's the one that I get constantly. Upright versus supine, awake versus asleep. And, it's funny that like these questions that come up, they're like legacy, they're things that people, it has to do with how these systems were first introduced into dentistry and how they were sold and how they were marketed. And in the old days, they actually used to label the graphs. They would be like, oh, this is your awake airway and this is your asleep airway. And so it's not necessarily true. I think dumbing it down for patient purposes, that might make sense. But really, we're not looking at what your airway exactly does at night. Dan, you addressed it perfectly. It's, what we're measuring specifically with pharyngometry is the propensity and ability for the airway to collapse, right? Sleep apnea is not a disease of size, it's a disease of compliance and collapsibility, right? We know that people with apnea have highly compliant collapsible airways. People that don't have apnea don't, right? So you can have a huge airway that's super collapsible and have severe sleep apnea. You can have a tiny airway that's a lead pipe and you don't have any apnea. So it has much more to do with the flexibility, much less to do with the baseline size. So pharyngometry specifically is not going to tell us how tiny your airway gets when you're supine in REM at night. I don't know what it is. But the fact that it can get small and has the ability to collapse and get small is very indicative and predictive of presence and severity of apnea. And then the flip side, if we can prevent that airway by repositioning you in some way from being able to collapse and get narrow, that improvement's relative to nighttime too, even though the actual numbers of what may be happening in your specific airway at night is obviously different. It's about that relative change and the ability to collapse. So, all that being said, we're going to look at rhinometry, which has nothing to do with collapse. So, rhinometry is real easy. So I put a nose tip on here. With rhinometry, different than the pharyngometer, there's no hole in this tube. So when you hold the rhinometer up to a patient, the first thing you want to do is make sure that you've got a good acoustic seal. So when you're starting the test, you want to make sure that it's up against their nose. And I'll do my left side first. You can twist this nose tip around however you need to. I always instruct whoever's doing it to, manipulate it around so that the start-stop button is right in front of you, so you're not having to go find it on the back of the tube, and then hold it up to their nose enough so that you get a good seal without jamming it in their nose or pushing their head off to the side or deforming their nose in some way. But also you'll hear the difference between a poor seal and a good one. You can start the test just in the room. You don't have to, doesn't matter. You can start it out here. And then when you hold it up to their nose, when I first start it, what you're gonna see is the line's gonna kind of be rising and falling. And the reason it's doing that is because I'm breathing, right? So when I exhale into a sealed tube, nose gets bigger, right? Creates pressure, opens things up. When I inhale against a sealed tube, it sucks it down and makes it smaller. So what you'll see is the line will kind of be fluttering on the screen. So once you have a good seal, we tell the patient to pause breathing, not hold your breath, not just stop where you're at. And what you should see is that line should stop moving completely. It should be totally stable. And then you grab it. See how it stopped moving? Everything's good. That's what we want. Again, I'll explain what the curve means and all that stuff in a second. We're going to do the next side. We'll do the right side after with rhinometry. So we just twist the nose tip around. Same thing, right side. Pause breathing. That's how long it should take. So without all the talking, rhinometry, both sides, takes 30 seconds. Once you have them up on the screen, so now we have two readings. Again, parameters being measured on the graph are two things. There's cross-sectional area, that's the vertical axis, that's the y-axis, and then distance, that's the x-axis. So in this case, wherever I put my mouse on this line, what it's really showing me is the exact opening. How big, how many square centimeters is the opening at that given depth, you know, and 0 here being the end of that nose tip, up to 3, 4, 5, 6, 7, 8 centimeters into the airway. So we're measuring through the nasal valve, which is this first dip right here. So, you know, what Dan talked about with nasal valve collapse or narrowing or restriction in the nasal valve specifically, you can see that real clear here. Not so much the collapse part, but you can see if there's obstruction, resistance, or narrowing just there. As you travel behind that, you should see two more noticeable dips. So the next one is anterior tip of the inferior turbinate. The third one is posterior turbinate tissue.
And
so
and that's the big question, is it like a valve or the turbinates, are they hypertrophic? That's the huge, it's not the septum, it's usually the turbinates. Can we get a pretty good feel for turbinate hypertrophy on these things or not?
you can. I mean, because turbinate tissue, it swells, right? It cycles and it swells side to side. So you'll see one side favor over the other, and then a couple hours later it'll flip to the other one. But if there's meaningful turbinate hypertrophy, if there's nasal polyps, if there's a severely deviated septum where it would be occupying space in one side, you would see that here real clear. You can overlay the two graphs.
My ENTs I work with, they love to see, when I send a rhinometry printout, they love to see that, kind of confirm what they're seeing on radiographs.
So you can overlay the two, and you can see like my left and right side now overlaying. This part of the reading is external nose, right? So this is out here. This is actually what you can feel and see. This is nasal valve, and then again, this is kind of once you've turned the corner and started traveling back into the nasal airway, and you can see, you know, there's some deviation there where, you know, one side is favorable. But if we look at just a blank graph for a second, you can see it clearly here. There's these three kind of diamond-shaped markers moving up the graph. And those are, the screen shaking, oh, it's the train. Those are statistical norms. So essentially what this first marker is saying, it's saying this is how big the opening should be at the nasal valve, right? Where this wide white line is. And then the red line on either side is the standard deviation off of that norm, and it narrows in both directions. So what we're looking for and what our notes would say, like within the software, is simply, was it within normal limits or not? Was there obstruction? Was there something taking up space that would be in some way inhibiting their ability to breathe properly through their nose? So if I look at my left side, I mean, I'm kind of above normal all the way through the range. I breathe fine through my nose. There's no obstruction. There's no resistance. If I saw something that was significantly deviated off of these norms, that's where I would at least ask a question. We'd start talking more about it. You know, maybe it's a situational thing. Maybe there's a lot of inflammation or allergy or something like that day that, you know, the inflammation is causing the problem. If that's the case, or regardless of the readout, I don't think there's anything I would see here where you'd say, oh, we're not going to do anything anymore. That's not what. You're just trying to see, do they have any obstruction that's concerning? If you saw anything that was abnormal, what I would do is retest them again the next time you see them, see if it's chronic and it's continuing, or it was just a situational thing that first day. If you see chronic obstruction here where their readouts are significantly below average and continuously below average, that's a situation where, you know, Dan talked a lot about UARS and RARAs and those high upper airway flow limiting events. You know, not so much the 45-second apneas where the guy's choking to death, but just these flow limitations that cause arousal, that trigger all these other side effects, but they're not going to measure as a full-blown apnea or hypopnea. Very often those live in the nose. So if you see chronic obstruction here, and now you're doing sleep studies and your sleep test, you might have a really low AHI, super elevated RDI, so you know you've got a lot of those raras. Those are kind of red flags to, you know, to dive a little deeper, maybe a referral to an ENT or somebody that could do something about this. Your limit to intervention here would really be limited to this first landmark, right? If you wanted to do like the, you know, the intake things or the nose cones or the mutes or the, you know, I like the mutes. I wear the little Rhinomed mutes with my appliance. Kind of addicting, honestly.
How far back is that going now?
It's going 8 centimeters.
And that's where?
That's into the nasopharynx. So that's like above the soft palate, but not down, not turned down into the
waterfall yet.
No, it hasn't fallen into the airway yet, but you're up in the nasopharynx and that kind of.
And
yeah.
Is that considered enough? That's enough information. That's what you're.
I feel like, yeah. I mean, it's not enough.
Yeah.
You know, it's not the whole picture, but
Right.
it's a piece of that picture. And yeah, so on rhinometry, in a reading like this, where I sat somebody down, did left and right side, everything is at or above or right around normal, no subjective complaints, I would probably just notate that it was within normal limits and we'd move on and probably wouldn't even go back to it again because there's no reason to.
I had a question. Dan,
Yeah.
do you know offhand, you know, during the day, I don't notice my turbinates altering. Is that only at night when we're sleeping, where they're swelling and diminishing? What, you know?
You're gonna notice it more at nighttime because, first of all, at nighttime, you've got about every 60 to 90 minutes, you have congestion, decongestion cycle.
Okay. So pharyngometry, real simple, same graph, same layout, just bigger scale, right? So our vertical scale now is up to 10 square centimeters. Our left to right reading goes 25 centimeters down. So we're measuring a lot further into the airway. We're measuring a much larger opening, obviously. So the scale is just a little bit different. Pharyngometry, we start with two simple tests. So the first one's our baseline. Baseline test, the way I describe it to a patient is just, I try to say as little as possible, but it's just how big is your airway? It's not whether it's good or bad or stable or unstable or anything. It's just what are we starting with? What are we working with? What did mom and dad give you for an airway? And then we'll move on to the next one, which is going to tell us kind of how does that airway behave? So the first test is real simple. They're going to put the mouthpiece in, tongue under, bite down, lips over, breathe normal through the mouthpiece. So if they can't accomplish that with instruction, then you pinch their nose so they're forced to just breathe through their mouth. It should look like this. Lines shouldn't be moving a lot. I mean, within a normal amount, obviously, because you're breathing, so there's going to be some more. There's going to be some more fluttering there, but it should be relatively consistent. Shouldn't be bouncing all over the screen. One of the things that I always tell people to look at is these On the screen right now is actually 3 lines. There's 2 dotted lines and there's a solid line. If they all look like they're relatively close to each other, that's a good reading. It means there wasn't a lot of movement happening. If there's dotted lines shooting up off the top and down off the bottom, that means when you stopped it, there was a lot of motion and you may not have a real accurate, reproducible position. What you're seeing with the solid line is actually the average of the last 10 pulses that shot into the airway and reflected out. So it's a little bit delayed in history because it's looking at the last, the last 10 clicks. And it's giving you the average. So anatomically, if we look at this graph, what we're seeing here, again, 0 centimeters being the end of the mouthpiece, right away we see a big spike up, to 7 square centimeters, something like that, a big increase in space. Now we're starting to travel further and further down. That's basically oral cavity, right? We're the first 4, 5, 6, 7 centimeters in, you're going through your mouth, so you have lots of open space there. As you travel further and further back, you have tongue, soft palate, uvula, tonsils, everything kind of converging together. There should be a meaningful choke point, in that 8 to 10 centimeter range at the oropharyngeal junction into the oropharynx. You should see an opening after 15 centimeters. This is the hypopharynx. This is between this is below the epiglottis. And then right around 20 centimeters, you should see a very noticeable drop off. That's the glottis, and then now we're into the larynx and vocal cords and bone supported tissue. This is not where sleep apnea lives. So sleep apnea happens because of collapse, basically between these 2 blue lines on the screen. You can see those vertical lines, right? So you're not happening because of the mouth and not happening because of the larynx. It's happening here, right? Somewhere in this spot is where everybody with obstructive sleep apnea has usually 1 or multiple points of obstruction.
What's the anterior blue? The front blue?
Anterior blue is OPJ, oropharyngeal junction. So it's the back of your mouth. It's tongue, tonsils, uvula. Yeah. Usually around 8 centimeters. I mean, obviously the lengths here could vary, somewhat, but it's close. So that's our baseline. Numbers come out here on the side. I know they're hard to see because it's kind of a darker green, but mean, average size for me is 4.1 square centimeters. That's good. There's nothing wrong with that. That's a big airway. Big guy, have a big airway, that's expected. But again, not good or bad, just how big is it? Although from a standpoint of trying to fix it, and I've done this a lot, I would much rather have a big airway that's collapsible than a tiny airway. Because tiny airways are hard to fix. Tiny airways, anatomically small airways, you're not growing them with these appliances, right? You're creating tone where there otherwise isn't tone, right? You're tightening up tissues, you're preventing collapse. But if it's just small, it's small, and it's hard to just make it bigger. So I would much rather have a big floppy airway than a tiny obstructed airway, because those are harder, in my experience. I don't know about you guys, but in my experience, those are much harder to get a good result on. So minimum number is just that, it's the minimum. So mean is average, it's the whole airway. Minimum is the narrowest spot. So at my narrowest point, which would be right here, it's 2.9 square centimeters. This number, if you look at the literature, all the stuff that got pushed out about pharyngometry specifically, you'll see it referenced as the MCA, the minimum cross-sectional area. That's a number that most often is correlated with the presence and severity of sleep apnea. So that's a number that we look at a lot because the airway is only as good as its most constricted point. All right, so that's baseline. If I sat down and looked at this reading, I'd say, great, we got a nice big airway, let's see what happens. So if the first test tells us how big the airway is, the second one's gonna tell us how small it can get. So we're gonna do the same thing with the patient. I mean, honestly, if I wasn't talking so much, I would have just left this right in their mouth. I would have reached over, hit graph 2, given them instruction and started. They wouldn't have even taken this out of their mouth. we'd flow right through it. But for the second test, nice breath in, slow and smooth, exhale everything out. Key with this one is to tell them never to stop exhaling, right? What you don't want them to do is push, and then pause. Because as soon as they stop pushing, their soft palate slams closed, and now they're holding their breath. They're not breathing in, but they've stopped breathing out. And that's really, really key to getting a good reading with this. So what you want them to do is just a pronounced, long, slow, smooth exhale. And what you're going to see, if they have an unhealthy airway, if they have an airway that has propensity and ability to collapse, what you're going to see is that line that starts out looking exactly like it was here is going to start getting smaller, right? And we're going to start seeing collapse. It's going to get narrower and narrower and narrower and narrower, and it's going to go down, 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 down. Your job as the sleep coordinator, whoever's actually doing this testing, usually not you guys, is to capture it when it's collapsed down as low as it's going to go. So you should see a nice smooth drop. It'll kind of pause. If you catch it, that's great. If you push them too long, they're usually going to take a breath. It'll pop back open, and you'll have to do it again. So here's our collapse. All right.
You collapse. Gee.
That's why I have this job. I just have a really crappy airway, so I have a great demo. I tried to lose some weight, and it made my airway better, so I had to gain it again just so I could keep demonstrating properly. All right, so now we have two airways on the screen, right? We've got our baseline, we've got our collapse. So now what's changed, right? So now my mouth stayed pretty much the same size between the two tests. That's good. But as soon as we get into soft tissue, obviously there's a huge, huge deviation. Specifically on that minimum value, the literature varies in what it thinks is normal. One paper was very specific. It said 1.86 square centimeters, or above is like a good target number. I've seen people say 1.5. One older paper said 2 square centimeters, but 0.4 is nowhere in the ballpark of okay. So when you see a reading like that, the likelihood that there's, at the very least, extreme snoring and very likely apnea. It's not a question of how, not a question of if they have it, it's a question of how bad is it. When you see a reading like this on a screening, because this giant black hole between those two lines is a problem, right? That flexibility is a lot, right? We're losing 78% of my airway. We're losing 86% of the minimum opening, and we're dropping down to a reading of 0.4 square centimeters, which is super narrow. So the questions that we get often, and were already asked, and we touched on them a little bit, is one, why do you do this upright versus supine? Certainly, especially in a dental chair, you could put somebody fully supine and you'd be able to get an easy reading that way. The reasoning behind it, aside from the fact that all the literature, paperwork, research, everything that's been done is done on upright people, is that when you take a sleep apnea patient and fully recline them and put them in a supine position, what you're going to see is they will unconsciously protect their airway. So you're now putting them in a airway compromised position, right? Their brain knows, hey, when I go on my back, you choke. So I'm going to thrust my tongue, I'm going to advance my mandible, I'm going to activate muscles to protect my airway. And now when you try to collapse it, they're fighting you the whole time. They're actually not letting it go because their body's protecting it from collapse. That same instinct or unconscious propensity to protect airway doesn't exist when they're upright. So you get a cleaner, more reproducible collapse every time when they're upright because their body's not fighting you off. So if I was on my back, these numbers would look different, but they would actually probably look better because, again, there would be compensation. So that's why we do it upright. Awake versus asleep, I think we addressed, right? So it's not exactly how big my airway gets at night. What I would ask people is if it's really bad like this, who thinks my airway gets better when I go to sleep, right? Nobody, right? So if it's awful now, we know it's at least this bad, likely much worse while I'm in REM on my back, right? There's really not much room for it to get worse, let's be real. I'm already at 0.4 square centimeters. Guys, if you walked in the room and I was hiding behind a curtain and you saw just this and you were like, hey, what's this patient, what's going on? What would you think is happening with my sleep and my airway? If you saw that baseline and collapse.
You're not breathing at night. You're breathing through a straw.
Right, breathing through a straw. And actually that analogy is good too, because if we look at that minimum, that's another question I get all the time. It's like, why didn't it close? Like by nature, with sleep apnea, you have, a full occlusion, right? You don't have, it doesn't get to a straw. Yes, it does sometimes, but eventually it's going to completely obstruct, right? So how come that didn't happen? And
Not asleep, that's right.
the reason behind that is two, one, I'm not asleep, but two, it's because I didn't try to breathe, right? Sleep apnea, and Dan talked about it, right? It's the attempt to breathe through that narrow opening actually creates that critical closing pressure to like collapse it the rest of the way, right? It's the paper straw analogy, right? If you have a big open airway, you can push air through it. You got a tiny little opening, you try to suck that next breath in, and instead of letting air flow through, it pulls it closed, right? And so if I had tried real quick at the very end there to suck a breath in, it would have collapsed, but it would also messed up all the tests. So that's why it didn't totally close.
Newton's principle.
Exactly. So, all right, so that's that. My only other thing I want to show with this is kind of the concept or the process with titration, why we do what we do. I know Dan's going to talk about that later too, and different techniques and methods for positioning. For me, I've been doing this a long time. I've seen every imaginable technique or method for how we're going to take bites and how we're going to position people, and how I can't even count the hundreds or thousands of cases I've seen where patients were given a device and just advanced kind of forever until something hopefully good happened. And they were in a bad spot. And obviously I know Dr. Teche is a huge believer in vertical because he's talked about it a lot already today. And in the cases he showed, he was using some pretty good verticals in there. But I've seen that over and over with patients. I've seen it personally. And I can illustrate it really well actually with these jigs. So, I can't if I can't get them out of the box.
John, when you put in the mouthpiece in your mouth, your tongue, that little piece, is your tongue below or
Below, yeah, below. Yeah, tongue's below. It's not pushing my tongue out of the way necessarily. It's really just giving your tongue something to do so that it doesn't go into the hole and block it. Yeah.
Or to go back.
Or to go back. Yeah. So it's
yeah.
just, it's giving it a resting point. When I have the jigs in their mouth, we're going to take the tongue depressor out. And, when I have an airway metrics jig in there, I always tell them, hey, you're going to feel how this is, you feel how this is positioned. You feel where that is with your tongue. I want you to keep your tongue right there underneath it so you can feel that same spot. That helps them hold their protrusion too, because one of the flaws with these bite jigs is that, you're just biting in these two tiny little, anterior grooves. If I pull my jaw back, it's just going to flip that jig, and I'm going to lose whatever protrusion I was trying to achieve with this. And so I always tell them to just kind of feel how that jig is parallel to the floor. I want you to feel your tongue under there and keep it that way. So if it starts pointing up at the roof of your mouth, I know they've pulled back and they're lost whatever position I was trying to find. But what I want to illustrate, and I think this makes a really good point with this, is, all right, fix this. Like if you got a patient sitting here and we're trying now to solve this problem of their tremendous amount of collapse, that's your job, right? That's your goal. If we're going to make an appliance that has some degree of success, we should be able to make that airway meaningfully less collapsible. And my whole gripe with methods about vertical doesn't matter and all you got to do is crank them forward and titrate them and advance them and all this, is that doesn't always work. So if I put in, this is a good example. So I'm going to put in a 4mm jig, so the narrowest vertical we have, and I'm going to go 7 protrusive past edge to edge. So that's as far forward as I can push, and as far forward as these jigs will measure. But if we're of the belief that that's all that matters is pull them as far forward as you can, that should be a home run position, right? That should be the slam dunk, hey, your airway is popping, right? So let's see how it does.
John, what's your retrusive to protrusive, by the way?
To start,
Yeah, to start.
pretty much edge to edge.
Yeah,
like my natural bite.
-2 and then plus.
Yeah.
10 plus?
Yeah.
Okay. Just wondering.
Although I can go maybe, I don't know what my total, if I did like a George gauge or whatever, maybe it would be like 8 or 9 forward, something like
Okay.
that, yeah. All right, see that? Out there. Way out there. All right. All right. So, first question, I mean, aside from that being super uncomfortable, right? Did it help, right? Did I make my airway bigger in this new position?
Small.
Yeah, I mean, I did make it bigger, right? If we compare my original collapse to this new collapse, it is meaningfully changed, but if all we're thinking about is advancing, then hey, that's it, John. You can't go any further than that. Now, I wouldn't be able to make them an appliance there anyway, right? Because I'm so far forward, that would be painful. And that's my frustration with this, is like if we're just stepping them forward, nothing good's going to happen. I'm going to fast forward in time and save you the step-by-steps of all of these.
Plus the graph is telling you that you need vertical.
Plus the graph is telling me that I need vertical. So this is totally anecdotal, okay? So this is just John's analysis of airway of a collapse. But I've seen probably more of these tests than anybody on earth, so I can say this with a fair degree of confidence. When I see a collapse test and it looks like this, right? What part of my airway is most obstructed, right? It's way up high, right? It's oropharyngeal junction, it's base of tongue, that's where I'm seeing the biggest obstruction. It's still not good down here in the hypopharynx, but it's worse up here, right? That's where I'm seeing the worst of it. In my experience, doing a lot of these, generally speaking, vertical tends to impact that part of the airway more readily, and protrusion tends to impact this part of the airway more readily. Now, it's not a perfect science, but anecdotally, like if I was going to go through this jig, instead of working through 15 different jigs trying to guess my way to the best spot, if I looked at this, I would be more inclined to do a higher vertical, probably edge to edge or +2 or something, but I would do something like that because that's where their problem is. If I saw somebody whose oropharynx was wide open and all their collapse is down deep, I probably would go with a 4mm vertical, but I'd push them further out. It's not perfect, but it tends to be where we end up. in my experience. So, for what it's worth, I'm gonna do a 10, because that's what I need, that's what my appliance is set at. 10 and 3. So we're gonna do the same thing now for the third time.
As a general rule, you figured out, you went as low and as protrusive for the first one. So why not?
Usually I wouldn't do that, right? So
Yeah.
usually I wouldn't do 4 plus 7. I did that as an example of, well, hey, like, let's just go as far forward as we can with the, you know, kind of like.
What I was gonna say, are you finding ever that, what if you went, like, it's not, I was trying to say, it's not necessarily true that going super far is the answer, sometimes
Halfway is the spot.
is the
I agree 1,000%. I would have never done that first, other than trying to illustrate a point.
But you gotta go through all the different positions to find it.
I would, if we were doing this the correct way, you know, or your sleeper system was doing it the correct way, we'd probably use the center line of jigs, we'd use the edge-to-edge bites first, and we'd go 4 millimeters vertical, edge-to-edge, test it, then we'd go to 6, you know, then we'd go to 8, and what you should see is an improvement kind of on a bell curve, right? It'll get better to a point, and then if you go one step further, it generally tends to fall off a cliff. And so go to the top of that curve. Now the top of that curve for some people might be 4 millimeters, and for me it's 10. But everyone's gonna be different. But once you get to that vertical curve, then we start saying, okay, well, 6 is the right vertical. Now let's start going +2, +3, +4, and you start stepping them out. The other thing we tell people to do, because you can do an unlimited number of tests on here, is as you try these new positions, change the name of the graph to match the jig. So like, you know, this first graph here that says titration, I would just click on the name and I would say 4 vertical, 7 horizontal, and I would change it to that name so that now, as you've done a dozen of these, you know, you come in the room and you're like, okay, well, that's the best one, clearly. What was that? And there's like jigs all over the table and you don't know which one was what. So yeah, just do it that way. But here, I'm gonna do a 10 and 3, just, which is where my appliance is. All right.
A lot of air in there, buddy.
You got to do a good job or it won't drop. All right, so now if you have kind of here's the concept, right? You have your original collapse, now you've got your new one. Obviously, aside from the fact that my mouth got smaller because this jig was in there, and we took the tongue depressor out, everything else, the part of the airway that matters, and yeah, look at that. When we added that big vertical, what happened to the beginning of my airway, right? Where I said it would be most impactful. We saw this huge improvement here. Still improved down here, just less so percentage-wise. But, you know, now you're looking at, you know, 144% overall, 325% improvement on the minimum. You know, we went from a 0.4 to a 1.7. You know, we're getting up really close to the normal range with that. That's significant. So,
And look at the cc's of air too, the volume.
yeah, the volume of the overall airway, yeah, huge. So we're seeing profound, statistically significant improvement. Again, nothing's guaranteed, but this would be highly indicative that this position would be, you know, would be ideal or would be, they'd be a great responder.
So would you agree, or maybe not, if this was a new patient and you saw that yellow line being at the minimum, what is it? What's the minimum? 1.7, right?
Mhm.
Would you think that 2 months after the wearing the appliance or so, the airway would be even more open?
I hope so.
Reduction in inflammation Yeah.
I think that's, I mean, we talk about like why we don't rush follow-up HSTs, you know, we don't deliver and then sleep test the next day, because if you wait 6 to 8 weeks, everybody says you're gonna get, with no titration, no change of position at all, you'll get a better result 2 months out than you would on night 1 for that exact reason, right? So it should improve even a little bit further from there. The other thing is when I make my appliance, now this comes to kind of a gripe with the different labs, and I'm sure you guys have all experienced this too. I've seen a lot of times where we go through all these pains of finding the right position, you send it off to a lab and they just invent their own bite wherever they decided to put it. And sometimes it's close and sometimes it's not. We've actually, like, I've seen some cases come back and you put it like on an articulator and it's nowhere near where your bite was.
A lab will call and say, listen, we can't create.
Right,
the appliance.
something's off, we can't do it there, we gotta do this. But I've also seen that if you, as long as they're close and they're doing their bite the correct, you know, they're doing it the correct way. And I know there's, you know, the big labs that we all work with out there kind of pride themselves on being very precise and accurate with this. I do see that, like, a lot of times you get, if you get your bite back at 10 and 3, just because it's so much more stable than that jig that's kind of fluttering in their mouth, you get an even better result than this gave us on the first shot. So,
Can I ask you a question? When
Yeah.
you're using both of the pharyngometer, or especially the pharyngometer, does it, nose being open or closed?
I always have patient pinch your nose. I don't, because patients don't listen. So when you say breathe through your mouth, they look at you like you have 2 heads, like they don't know how.
So you advocate.
Pinching the
closing
nose,
your
yeah, always. Because if they flip, if they start nose breathing, it just pushes that soft palate closed. Yeah, so if I do, like, just to see, this is what breathing through my nose looks like. So nose breathing, you see a flat line basically, because the soft palate's pressed forward, it's basically shutting it off, and you're just breathing there. So, and then what you'll have people do is breathe in and then breathe out through their mouth, and then it just moves all over. So yeah, pinch your nose, breathe normal through your mouth.
You or maneuver.
Yeah.